First of all, I'd like to thank all of you for inviting me to participate in your meeting. And I'm very excited to share with you some of our practices here in Malaysia, especially at our center. So I'm here to make a case of precision angioplasty. Should OCT intravascular imaging be a routine practice in all of your angiography or angioplasty cases? Once again, I'm Dr. David Yong, a consultant cardiologist here at Gleneagles Hospital, Kuala Lumpur, Malaysia. So before we start, I would just like to talk a bit about one of the passion of mine is coronary physiology. I think this is nowadays often emphasized. I think physiology still play a very important role in our day-to-day practice. And I think in today's practice, it's very difficult to practice cardiology because there's so much data out there. You can name hundreds of clinical studies and new ones are being published every year. And I'd just like to highlight some of the very important studies that we have, especially in terms of physiology. We have the DEFER trial, which tells us already that deferring a lesion that is not FFR significant actually improve patient outcome. Then, of course, we have the famous FAME trial and the FAME2 trial, which shows that multivessel PCI guided by physiology is actually more beneficial compared to those just on fluoro base. And then, of course, after the ACS event, there's also clinical data to show that from the complete FIRE and full REVASC trial to show that complete revascularization for patients after an ACS is also beneficial. But what I'd like to pay more attention to is the PREVENT and the combined OCT FFR clinical trial, which actually try to tell us that in certain situations when there's non-flow limiting, meaning FFR negative, physiologically negative lesions, there might still be a benefit of pursuing with a clinical imaging, looking for such thing as a vulnerable plaque to guide us in whether these lesions need to be treated or not. And I have a privilege to be involved in the combined OCT FFR trial. So just to refresh our memory on the FAME trial, basically it's a very well-designed trial which involves patients with multi-vessel CAD. And I think in our clinical scenario these days, multi-vessel CAD is still a major issue for us, and we tend to still send the patient for bypass. And surgeons keep saying, why are you stenting left, right, center, all these patients? Maybe, you should send them to them. But then we know that, incorporating physiology to our clinical practice, especially in multi-vessel PCI, is well studied here in the FAME trial. Comparing FFR-guided PCI and PCI angiography alone, there is a significant reduction in clinical outcomes from the primary composite endpoint of composite death, MI, and repeat revascularization. And this is clinically significant, mainly driven by death or MI, which is a real hard outcome that we need to pay attention to. At the end of the day, we as physicians, we want to prevent death. Now, when it talks about imaging in today's clinical practice, cardiology practice is extremely important. And I think we are using it more and more often. In my day-to-day practice, I would say 80 to 90% of my patients are actually imaging guided. If it is reimbursable, the patient can afford it, then I don't see a reason why we shouldn't use imaging. And more data has come out in the recent years. I think in the last 2 years or so, there is this Renovate Complex PCL trial, which I really like to commend the author, and I have a privilege to meet them, this Korean study. And they actually managed to recruit a large number of patients with complex coronary artery lesions, being true bifurcation lesions, CTO lesions, PCI of unprotected left main, implantation of stent, long stents more than 38 mm, multi-vessel PCI more than 2 vessels. These are lesions that you should not take lightly and should pay extra attention to. And if you need more than 3 stents, in-stent restenosis, severe calcified lesions, or even osteo lesions, this group of patients will actually randomize 2-to-1 to an imaging-guided strategy and an angiography guided strategy. When you look at the clinical trial here, the primary endpoint, there is a significant reduction in events in imaging-guided PCI compared to angiography-guided PCI alone. And target vessel failure also is significantly down. No matter how you look at it, OCT versus angiography, IVUS versus angiography, imaging still is superior. And interestingly, in this study, OCT versus IVUS, somehow the OCT group seems to have a numerically superior compared to IVUS. Yeah. Now, because of all these various guidelines, various clinical data that is available today, Intracoronary imaging by IVUS or OCT is recommended for performing PCI on an anatomically complex lesion. They put it here in the 2024 ESC guideline, complex lesion, in particular left main stem, true bifurcation, and long lesion. I think this is now a class 1A indication, we all agree, but I believe that we should use for even a wider array of patients, yeah, those that run-of-the-mill PCI could also be done better with imaging guidance. I am sure that if any one of us were to go for an angioplasty, we would want ourselves to be done under imaging guidance and not just based on fluoroscopy alone. I think Abbott has come up with a very good algorithm, the MLD max algorithm. You just need 2 runs, one before, one after. We are very familiar with this. And the M being the morphology, we want to know whether there's calcified lesion, how bad is the calcium, whether it's fibrous lesion, fatty, lipidic plaque, and so on, the length and the diameter. And we can actually measure the lesions through until the very millimeter. Yeah. So it's like going to a tailor. You go to a tailor, you get well measured suit, fit to size, and you want your stent to be like that as well, not a single millimeter more and not a single millimeter less. And the sizing should be absolutely right and should be well fitted. Post implantation should be well expanded, no stent edge dissection, and no medial dissection, and also well opposed.